So genetic testing, this one's kind of a fun talk. So imagine you went to the world's largest Chinese restaurant and they handed you the menu that was the size of a phone book with all the different things you can order. That's kind of what genetic testing is getting to these days. Really, I was sitting on one of the NIH panels for new genetic tests, and we just kind of gave up eventually because they were coming out faster than we could track them as far as that goes. And there's some really good centers nationally, and actually there's a real good one up in Gaithersburg too. But genetic testing is a concept that's really at a crossroads. So when most people think of geneticists, they think of people kind of locked away in a small tower somewhere doing very rare diseases that nobody's really that interested in because they're insanely rare other than biochemists and folks like that. And that's been historically accurate for what my field does. We tend to deal with the rare and the unusual and the not particularly everyday sorts of things. That's changing. Genetics and genetics testing is intruding into the mainstream more and more. For instance, in the field of cardiac surgery right now, there are genetic variants that we work with the cardiac surgeons that are the best predictors for postoperative outcome in pulmonary hypertension. If you are putting patients on coagulation medication, there are genetic variations that will help you adjust your dose. If you are giving high-dose chemotherapy or chemotherapy to a patient, there are genetic variations in the processing of the chemotherapy and in the responses to that chemotherapy that will make you adjust your dose. So the crossroads we're at is going from these very rare tests for these very rare diseases to more common genetic testing that will eventually be a part of everyday medicine. I would hope that someday, from those newborn screening cards with the DNA we check from those, I can call your office up and say, this is a patient who's likely to have an extreme febrile reaction to a series of vaccinations. We may be able to do that at some point in time. Or this patient is at very high risk for a particular type of influenza strain because of their IgA conformations on their DNA. Or you can almost paint out a whole variety of scenarios. It actually gets too complex at some point. But that's where these things are kind of heading. So we're really playing in the cancer field, infectious disease fields, drug metabolism. Then there's what I like to call recreational genetics. How many of y'all have seen, I know that sounds kind of creepy, but you've seen the 23andMe? Well, recreational genetics you could also say is having kids, but that's a whole different... That's not actually what I meant. Now that I think about it, I'm going to have to rework that slide. Or maybe I'll leave it the same, actually. I got a good laugh. But if you've seen them on like the 23andMe testing where you take a little cheek swab, send it in, the National Geographic Genographic Project where you can track your X chromosomes and Y chromosomes back through history. So there's all sorts of things coming up as we look at DNA variation. And if you think about it, you've got 6 billion bases of DNA, 3 from mom, 3 from dad. In that, there's at least 10 million different variations on the theme in there. So there's a lot of variability in the human genome, some of which means nothing and some of which actually is highly significant. And we're sort of in the thick of trying to figure out what to do with that. So given, though, where we are today, you know, this is all kind of nice stuff, and I could sit here and tell you about how personalized medicine is going to revolutionize that, but you can pick up Time magazine and get that, and it's not here right now. That's something that's going to be coming. What should you be thinking about now as far as doing genetic testing? Patients with birth defects, that's sort of the old classic. Deformations and malformations, things that didn't quite go right during the processing of making a human being. Chronic or degenerative diseases, which you do not have a clear explanation for. Things where patients are getting worse, where things are getting worse. Abnormal newborn screening, which we just spent some time talking about. Cancers. Developmental concerns. Interestingly enough, now with our current state of testing, 10 to 15% of the genetic tests we're doing on kids with just developmental delay with no abnormal features are positive. So it's actually getting to the point now where we can pick up a lot of things in kids that don't have anything necessarily funny looking about them. Autism. This is a field that is fraught with peril from a geneticist standpoint because once you start trying to define what actually autism is, I could probably get however many people there are in this room's definitions of autism, and my wife's a developmental pediatrician and she'll whack me in the head for doing that. Family history. There's a family history of a genetic condition. Oftentimes the family want to find out if the child is a carrier or they're carriers themselves. And then eventually actually genetic testing will be used as a screening tool. In cystic fibrosis, we're already doing that to a certain extent. Sickle cell, we're doing that to a certain extent. You're probably going to see expansions on that. So levels of genetic testing. Think about this like taking satellite photos. So if you go back to the 1950s, satellite photos of Earth were grainy. You could kind of tell North America was there. Florida was sort of stuck on one end, and that was about all you could do. That's kind of what we can do with chromosome analysis. So your classic karyotype will tell you that you got 46 chromosomes, you got an XX or an XY. It'll tell you big chunks of real estate are missing from those karyotypes. You know, you're going to pick up your classics there, your Down syndrome, things like that. Then we went a little more sophisticated. We went for something called fluorescent in situ hybridization, which we still use both of these tests a fair amount. That's where you take a large probe, you make it so it'll glow in the dark when you hit it with an excited laser or light, and then you probe the chromosomes and you see if those pieces are there or not. That's for things like DeGeorge syndrome, Williams syndrome, where there are large chunks of missing DNA. Then you kind of come where we are right now, which is fragment analysis or chromosome microarray. The current panels for chromosome microarray, we take about 180,000 small pieces of DNA, and then we hybridize them or bind them to the patient's chromosomal DNA, and we look to see how many copies there are of everything. What we hope is for almost everything except the stuff on the sex chromosomes, we're going to find 2 copies. Depending on if it's a boy or a girl, things like this. This is really starting to replace chromosome analysis as our first-line screen. In fact, most genetics clinics now will do chromosome analysis as a secondary screen after doing a chromosomal microarray. This is exquisitely sensitive. It will pick up the classics, like an extra 21, things like that. It will pick up the DeGeorges. It will pick up anything where there is a missing or duplicated piece of DNA. What it won't do is it won't pick up rearrangements of DNA where it's balanced. So if a piece of 1 got swapped with a piece of chromosome 2 and no DNA was lost, you won't detect that. But those are pretty uncommon scenarios and typically not associated with a clinical phenotype. They can be, but that's unusual. So chromosome microarray is kind of what we use now as a frontline screening for the things we're talking about. The next step in resolution, so we've sort of gone from our grainy picture to a picture where we can kind of look at cities. Chromosome microarray means we're looking at streets and houses, so it's about where Google Map is right now, so you can actually look and see your house on the satellite view. The next one is we go inside the house and we rummage through your drawers. That's sequence analysis. Sequence analysis, though, remember, you got about 6 billion bases, so we're not doing whole genome sequencing right now. The level we're at right now is we're doing either single gene sequencing or we're doing panels of genes to sequence. And you're going to see a lot of new panels coming out over the next year. That's going to go in and look at the code for that DNA, see if there are any major abnormalities. Each one of these has an upside and downside, and we'll talk about that a little bit. We do mitochondrial DNA sequencing, so there's a couple of good techniques for that. High throughput sequencing has really come a long way, so actually the turnarounds aren't bad. And then we do functional testing. So sometimes you've got to see if actually whatever's going on in the blueprints actually matters any as far as that goes. So we talked about the newborn screen testing already. Biochemical testing, which we can do blood, urine, and CSF. Functional enzyme testing, which you can do on a relevant tissue, whether it's a piece of skin, a white cell in the bloodstream, or a piece of liver, things like that. Tissue staining, and then different kinds of metabolic profiles. The last group is kind of used more in a specialty setting than it is in a general clinical setting. Examples of diseases we kind of talked about already: Down syndrome, DeGeorge, Prader-Willi syndrome, where you can look at that either by chromosomal FISH analysis or microarray analysis. Duchenne muscular dystrophy, you want to typically do by sequence analysis. Mitochondrial diseases, you can do by sequence analysis, genomic sequence, or an assay. Galactosemia, we talked about before, you would actually do that primarily by a biochemical assay, and then we'll actually look at the protein and we may go to sequencing with that. And then for autism, we can do all sorts of things, some of which are relevant and some aren't, but typically we'll start with a chromosome microarray and work our way in from there. So 2 main types of genetic tests. One are for constitutional findings. That's stuff you're born with. So that's what you started out with. That's the bulk of what we'll do in a genetics clinic. The other types of genetic testing you'll see are for acquired conditions. And there's sort of two things you'll see there. It's done a lot in cancers, in leukemias and solid tumors. They'll do chromosome analysis or molecular DNA analysis of tumors, which will predict their outcome, their staging, and actually that's now used in developing a lot of chemotherapeutic regimens for patients. The other place you're seeing a lot of DNA and RNA testing is in microbiology. These things are exquisitely sensitive if you're looking for different types of bacteria or viruses. You can do them on CSF, you can do them on plasma, you can do them on urine, and you can get the turnarounds a lot faster than you can a culture. So you're seeing a lot of microbiological DNA testing. I know we do a fair amount at Children's and other places do as well. So molecular testing, for an example of that. So if you wanted to use the classic, like I said, Duchenne muscular dystrophy is one of the classics. Hemophilia is another one of the classics for that. The things you have to remember about this is these are often hard to interpret. The DMD gene is huge. It's over 1 million bases in size. And there are no common mutations. So unlike sickle cell anemia, where we have one mutation we have to deal with, in Duchenne muscular dystrophy, every family is different. So we actually have to go in and say, have we seen this mutation in anybody else? Do we know what it actually does? Things like that. All right. So what use is it to do this testing on patients? So what? That's the question I get a lot of times. So I look at this patient, I know they got Down syndrome. What the heck do I need a karyotype for, or what do I need a chromosome microarray for? Well, a couple of things. For instance, Down syndrome can often be the result about 5% of the time of a chromosomal rearrangement that the mother can be a carrier for. I can tell you I've seen, I don't know, probably 20, 30 cases in my career where somebody in the community said, no, this won't happen again, and sure enough, the next kid had Down syndrome. Because 1421 translocations are fairly common, and if you don't pick that up on the kid, you won't know to check the mom or dad or know if they're a carrier for that. So for one thing, it's to know about future risk for the family. The other thing is testing siblings for affected status. Now, a lot of the diseases that present in the newborn period, that's not as big an issue. If you've got a child with Down syndrome, it's pretty easy to tell if their siblings have Down syndrome or not. If you have a patient who has say a mild or moderate urea cycle disorder that gets unmasked by when they get influenza and it tips them over the protein catabolic step, they could have siblings at risk and they just haven't had that environmental stressor yet to do it. So actually being able to screen the siblings can be very useful and actually prevent problems in the future. You can do pre-implantation genetic diagnosis. That's something we get a lot of questions about. How do we keep this from happening again? What do we do for these sorts of things? And we're getting better about being able to predict prognosis on a lot of these patients. We're starting to be able to tell this particular mutation in this disease is going to be a more severe outcome or a milder outcome. But where we'll be heading next with stuff like that, for instance, I see Dr. Teach back there. He's probably going to be talking about asthma or something like that. And as he can tell you, there's a lot of genetics coming out in asthma about severity of disease, response to medications, things like that. So we'll start moving into that field more and more as time goes on. Karyotypes, we talked about that and what the use is of those. I don't really need to show you that. Let me show you a little bit about microarray, though, because this is the one I would say most pediatricians run afoul of, because they'll typically order it and you don't really quite know what you're getting for that. So this is what the reports, well, this is actually what the test result looks like. So you've got these hundreds of thousands of little fragments that you've hybridized to the DNA. And what you want to see is that you've got two copies of everything. Of course, you'll see differences on X and Y. But what you'll find is then you'll get dropout if you're missing a region, or you'll get an increase in signal if you've duplicated a region. The beauty of this system is we can almost pinpoint within 10 or 20,000 bases right where that occurs. So it allows us to make some very, very accurate predictions on what genes are missing and which ones are duplicated. We're picking up a ton of things that we didn't know existed. When we first started doing this about 8 years ago, we were getting a hit rate on patients that we had failed with karyotypes of about 30 to 40% on patients when we went back and worked them up with microarrays. Now, if you just take any patient walking into a genetics clinic for evaluation that we send a microarray on, the hit rate's about 15%. In pediatric offices or non-geneticist offices where people are sending those, the hit rate's about 8 to 10%. You say, that's great, but what do you do with the results? The problem is this test is so sensitive, you will pick up a lot of polymorphisms. By polymorphisms, I mean changes that don't necessarily cause disease. So when we find one of these new ones, which is almost on a regular basis, the first thing we do is we go back and test the parents. If the parents look pretty normal, which sometimes they do, sometimes they don't, and they have that same polymorphism, then we say, okay, this is more likely to be a benign variant, given the fact that there are differences in inheritance from mom and dad on DNA, and that can actually play a role in there, but we won't go into that. That takes a little longer to go into. But we'll test the parents to see what's going on there. The other thing we'll do is we'll go through and find out what genes are missing or duplicated in that region to see if that will give us some prediction on that. For instance, if it's an oncogene or a gene that affects neurodevelopment and is known to do that and it's missing, it's pretty likely that's the smoking gun as far as the neurologic problem that patient has. So the libraries of knowledge on this are building currently. They're not where they need to be yet, but they're actually getting pretty good. So even compared to 2 years ago, the predictive value of this testing has improved tremendously. I don't recommend you do it as part of routine office practice. The problem is if it comes back positive, which it's likely to do in a lot of cases, you may not, it's kind of hard to talk a family through what it means and what to do next about it. If you really want to get one of those, we'd be happy to help out with that, or get somebody who works with it on a regular basis to send the testing, because then they can clean up when you get that. And we end up having to clean up a lot of those messes, and sometimes the family will think that they have a devastating problem that they don't have, or they don't have a devastating problem when they do. So for this type of testing right now, it's still in flux enough where I don't necessarily recommend it for the casual user, shall I say. So that's just something to kind of keep in mind. All right. Biochemical testing we already talked about. I did want to follow up with one thing on newborn screening. There are things newborn screening will not pick up. Okay? It's good for the things it does, but you should remember that there are lethal newborn conditions that newborn screening will not detect. So if you have a patient who's lethargic, sick, ill, and you don't have a good reason for it, and they've got a normal newborn screen, please don't make the assumption it's not an inborn error of metabolism. It just simply may be one that's not on the list of the things we can easily detect. The urea cycle disorders are particularly famous for that. You can have an ammonia of 2,000, remember normal's 35, be in a full coma and get a normal newborn screen on that patient. So just kind of keep that in mind. You can have metabolic disease in the face of a normal newborn screen. All right. Now, acquired mutations, not a whole lot to say about this. This is more the purview of pathologists and oncologists, other than to say that they will look at chromosomal rearrangements in growth genes and molecular rearrangements, and that will actually affect what they're going to do as far as treatment goes. All right. Since I have a flashing red light, we're going to kind of cut to the end here. What are the challenges of doing this? It's a changing testing environment. Like I said, I can bet you that between Monday and today, there have been 1 to 2 new molecular genetic tests introduced into the commercial laboratories. And if you go in the catalogs, they update them on a weekly basis. FDA and CLIA is still trying to work out how they're going to certify all of these. We have tests that are CLIA approved that are not FDA approved, and vice versa. And a lot of those, the laboratories are reluctant to go through that extensive testing if we're going to use their test anyway, because of the how often they'd have to do that. And insurance issues. We spend, I figured it out, we spend $63,000 in our division getting approvals just for chromosome microarrays per year. Simply because we have to explain why, what the test is for to actually get approval. And you want to get approval for these because they cost anywhere between $1,500 and $2,000. And you want to get approval for these before you send them so the family isn't stuck with that. And we've got about a 95% approval rating for these, but it does take some time to do it. It takes about 30 minutes per test to get that. And I've actually got people to do that sort of thing. If you ever get in the situation where you need and you want some text, we've got a couple of scripts for that on why we need it. Test interpretation. The biggest thing is if you're sending anything for sequencing or chromosome microarray, you are likely to get results back that may be difficult to interpret. If you involve us a little sooner, we may be able to help you with that. But even if you do it and you get one, we'll still help you sort it out and figure out what's going on. Just don't hesitate to call us. Need for testing relatives. A lot of the labs will do it for free right now, but you still have to track everyone down. Then is it a real mutation or is it just a variant of unknown significance? Which, when you start talking about 10 million variations per person, you realize that the odds of finding one of those are pretty high when you start doing sequence analysis. All right. Sequence panel testing is coming out. Chip-based sequencing is the big one. That's that. You're going to see panels for all sorts of things. You're going to see autism panels. You're going to see seizure panels. You're going to see heart disease panels. There's going to be a lot of push, and you're going to see a lot of marketing around doing these. There's probably going to be more and more direct-to-consumer DNA testing. People are offering these kits to folks. One of the things we're trying to gear up for is how to deal with the fallout from that. So that's just part of what you're going to see in the landscape in the next few years. The infectious disease stuff we already talked about. Where do you go for help? Kind of the same thing with newborn screening. We have 9 genetic counselors. They're all pretty good at their jobs, last time I checked. And they can help you with that, but there are also online sources like gene reviews, gene tests, online Mendelian inheritance in man, and the laboratory testing sites as well, depending on where you're sending your testing. A lot of the labs will have a genetic counselor to help you with that, but we'll help if we can. So that same number I gave you for the newborn screening, 202-476-6287, is our division number where you can also get genetic counselors as well to help out if you've got testing questions, anything like that. And we'll be happy to see your patients. Thank you all very much for your attention.